Hi everyone, thanks for listening to this presentation. My name is Michelle Kuznicki. I'm a first-year gynecologic oncology fellow at the Cleveland Clinic. I'm going to be presenting my research titled Clear Cell Histology, Microsatellite Instability, and Immune-Related Toxicity are associated with improved outcomes in gynecologic cancer patients receiving checkpoint inhibitor therapy. I have no disclosures. To start off with a background of checkpoint inhibition in oncology, tumors can evade the immune system by binding specific inhibitory T cell receptors that activate a molecular checkpoint within the T cell to dampen its activation. Checkpoint inhibitors are monoclonal antibodies that disrupt this interaction by binding with either the tumor ligand or PD-L1 or the T cell receptor, either CTLA-4 or PD-1. Checkpoint inhibitor therapy is very exciting because it can lead to durable responses even in some previously treatment-resistant tumors. However, not all patients respond to checkpoint inhibition, and immune-related toxicity is of concern. So identifying factors associated with response to checkpoint inhibition can allow for optimization of patient selection. Previous data has reported that microsatellite instability, or MSI high status, which is a DNA mismatch repair deficiency, as well as PD-L1 positivity as predictors of response in checkpoint inhibition in gynecologic cancer. However, additional reliable predictors of response have yet to be identified. The aim of our study was to identify prognostic factors associated with overall response rate and progression-free survival with checkpoint inhibitor therapy in gynecologic cancer patients. This was a IRB-approved single-arm retrospective cohort study. We included patients who had received at least 2 cycles of checkpoint inhibitor therapy. We retrospectively abstracted data through the EMR, including data such as patient demographics, primary tumor characteristics, treatment data, and response data. PFS was compared by univariate Cox regressions, and univariate analysis was performed for prognostic factor evaluation. Our primary cohort included 72 patients who met inclusion criteria. 20 of these patients were ovarian cancer, 36 endometrial cancer, 13 cervical cancer. 2 patients had immunostaining consistent with gynecologic origin, however, the exact disease site could not be specified, and 1 patient had vaginal cancer. In the overall cohort, we identified a partial response rate of 22.2%, a complete response rate of 8.3%, with this overall response rate being highest in the endometrial cancer cohort with an overall response rate of 41.7%, followed by ovarian with an overall response rate of 20%, and cervical with an overall response rate of 15.4%. We also had a stable disease rate of 36.1%. Looking at the duration of response, and duration of stable disease were pretty consistent at 6.6 and 6.2 months respectively. Progression-free survival for the entire cohort was 6.4 months, and overall survival was 15.2 months. On initial univariate analysis of overall response for the full cohort, we were unable to associate age, primary disease site, performance status, grade, number of prior lines, prior pelvic RT, or PD-L1 status with overall response rate. We did, however, find that MSI high status was associated with a higher overall response rate with a 54.2% response rate in MSI high patients versus 25% in MSI stable patients. Given that the ovarian and endometrial disease sites overlapped more consistently for progression-free survival outcomes and histologic patterns, this group was selected for a sub-analysis to evaluate for further predictors of response. On initial analysis, we were unable to associate age, performance status, grade, MSI status, prior lines, or prior pelvic RT with overall response. Interestingly, in the full cohort where we did see a significant association with MSI high status with response, and this subgroup we did not. So I'm looking into this a little bit more closely. Out of the 6 MSI stable responses, 4 of these were clear cell histology. 3 of them were ovarian and 1 was endometrial. So to reduce confounding, we created a separate analysis group of MSI stable clear cell patients. On repeat analysis with these updated analysis groups, we did find a significant benefit in the MSI high group and the clear cell group compared to the MSI stable group, with an overall response rate of 11.8% for MSI stable, 52.2% for MSI high, and 57.1% for clear cell histology. On looking at the progression-free survival for these updated subgroups, we found consistent results. The MSI stable, representing in blue here, had a median PFS of 4.7 months. This was followed by MSI high, represented in red, which had a median PFS of 10.0 months. And then finally, clear cell, which is represented in green, had a median PFS of 12.5 months. 1-year recurrence-free survival was consistent with this. On analysis, MSI high did have significantly longer progression-free survival compared to MSI stable. And although the progression-free survival was promising in the clear cell cohort, the numbers were unfortunately too small for a formal PFS analysis. Another small subgroup that we identified were patients who received checkpoint inhibition as primary systemic therapy due to refusal of traditional cytotoxic chemotherapy. This included 6 patients. They were a little bit older than the full cohort with a median age of 79.5. They all had significant medical comorbidities. All of them were endometrioid histology who had received prior pelvic radiation. They were being treated with checkpoint inhibition in the recurrent setting, and they were all MSI high tumors. Regarding their checkpoint inhibitor therapy, they all received pembrolizumab. Their response rates were pretty impressive. All 6 of them received clinical benefit from checkpoint inhibition with an 83.3% response rate. 5 out of the 6 patients had a partial response. The duration of response was approximately 9 months, and the progression-free survival was 7.3 months, with 5 patients being progression-free at last follow-up. The overall survival was 9.5 months, with 3 patients being alive at last follow-up. 2 patients had died of intercurrent disease, and 1 patient died of disease during follow-up. So this goes to show that, although these patients were elderly with significant medical comorbidities, they did have reasonable outcomes with primary systemic and checkpoint inhibition. Looking at immune-related toxicity outcomes in this cohort, out of our full cohort of 72 patients, we had an immune-related toxicity rate of 40.3%. 9.7% of patients required hospitalization due to this toxicity, and 12.5% of patients required discontinuation of therapy due to this toxicity. Interestingly, on both the univariate analysis for overall response and for progression-free survival, the presence of toxicity was related to improved outcome compared to the absence of toxicity. So in the top chart, you can see that the overall response rate for patients who experienced immune-related toxicity was 44.8% compared to 20.9% for those who did not. And on the bottom, you can see that the median progression-free survival was 12.9 months for those who experienced immune-related toxicity versus 4.7 months for those who did not. So in conclusion, we identify clear cell histology as a prognostic factor associated with improved response to checkpoint inhibition, and this may further guide optimal patient selection for therapy. We also confirmed the previously demonstrated prognostic factor of MSI high status to be associated with improved overall response rate and progression-free survival. We identified that checkpoint inhibition as primary systemic therapy for MSI high recurrent endometrial cancer may be reasonable for patients with limited treatment options. And finally, the development of immune-related toxicity was associated with prolonged progression-free survival and overall response rates, and further investigation of this finding may be of therapeutic value. Thank you all for listening to this presentation. If you have any questions about the research, feel free to email me. It's my last name, kuznicki, my first initial M, @ccf.org. Thanks for listening.